Good morning and welcome to an online event brought to you by Parkinson's Community Los Angeles. Today we are talking about balance, gait, and foot concerns in Parkinson's, and we're with podiatrist Dr. Sam Sanandaji. I'm Judy Yaris, and I serve on the PCLA Board of Directors. For those of you who don't know us, we are a nonprofit that supports families living with Parkinson's disease through free events like this one, and support groups, and so much more. Today's Let's Talk Parkinson's program is brought to you by our generous Let's Talk Parkinson's sponsors, Abbott, Boston Scientific, Medtronic, Kyowa Kirin, and Supernus, and by donations from the Parkinson's community. If you appreciate what we do, please make a donation on our website at pcla.org. And thank you. Just a few quick notes before we get started. We're recording today's event for YouTube. You will only be visible in the recording if you are speaking. Please stay muted to keep background noise at a minimum. And after the presentation, there will be time for questions. You can submit them through the chat. Now, please join me in welcoming our speaker today. Podiatrist Dr. Sam Sanandaji has been in practice for almost 2 decades. He is the Division Chief of Podiatric Surgery at Cedars-Sinai Medical Center, board certified in foot surgery by the American Board of Foot and Ankle Surgery, and as well as the Chief Medical Officer for the Foot and Ankle Care Center in Beverly Hills. He is board certified in foot surgery by the American College of Foot and Ankle Surgery and skilled at both the medical and surgical treatment of foot and ankle issues. And now, Dr. Sanandaji, thank you for joining us today.
You're very welcome. Thank you for having me. Actually, you could go to my first slide. My first slide is to thank you, Judy, Sarah, for everybody helping to organize this, and also to the community at large. I'm very blessed to be able to join you and to give you my knowledge and hopefully help on your day-to-day journey with Parkinson's. I also want to thank my patients with Parkinson's, my residents, my assistants who helped me not only with this presentation, but on a day-to-day basis to learn more about this condition and be able to help others. So let's get started. Generally, there's 2 different types of Parkinson's. I'll go through my slides and there'll be more time available for questions like Judy said at the end. So I'll be happy to field any questions. So generally, there's 2 types of Parkinson's. There's a tremor-dominant Parkinson's disease, as well as the partial instability gait difficulty. Next slide. So for the tremor dominant, and that's 75% of patients with Parkinson's are diagnosed with this. It usually starts around the age of 45 to 55, and usually starts with a tremor in one hand, but then it can progress as it goes to tremor on the other hand and the other parts of the body being involved. Interestingly, it does not involve tremor of the head. Tremor of the head is usually referred to as essential tremor, which is not Parkinson's, even though a small percentage of essential tremor patients may eventually be diagnosed with Parkinson's. Next slide. So partial instability gait difficulty, this is 25% if you do the math. But in addition, this is where most of the fall risk can occur. Symptoms are the shuffling gait, balance issues, and tendency to fall. And it has, unfortunately, a more rapid progression, and they don't respond as well on a long-term basis with anti-Parkinson's medications like levodopa. Next slide. This is the subdivision based on onset. So the juvenile form of Parkinson's occurs in children, and that's extremely rare. The young onset form of Parkinson's is generally between the 20s and 30s, and that's Michael J. Fox. He was in his late 20s when he was diagnosed. and that responds well to the levodopa. But because of the extent of use of that type of medication, it can lead to side effects, such as dyskinesia. The later onset Parkinson's is more the PIGD form, and that is early gait difficulty, balance problems, as well as cognitive decline, as well as mainly dementia. Next slide. So there's 5 stages according to the Hoag and urine stages. Each one of these stages is basically helping to determine where the patient is and their progression as the condition advances. But stage 1 is when they have one-sided issues or unilateral tremor, bilateral tremor, stage 2, or bilateral symptoms. As it progresses, balance issues and able to walk without assistance is stage 3. Requiring assistance with walking is stage 4, and stage 5 is the most advanced form. Next slide. Another staging scale, which is the Unified Parkinson Staging Scale. This assesses cognitive difficulty in 2 general categories, and it assesses both the mentition, behavior, and mood, and it looks at different types of intellectual impairment, thought disorder, depression, motivation, initiative, and then the second category is the activities of daily living, such as speech, salivation, and swallowing. Each one of these individual sections has a 4-point scale, and as you add up the numbers on this test itself, it gives you an idea of where the patient is in terms of their overall progression. Next slide, please. So this was that test that I was discussing, the Get Up and Go test. So generally, anything that is more in the 14 seconds or higher is what's suggestive of being more prone to falls. I have my residents take this test, and I have them actually do it twice. I have them do it once normally when they just get up, go, and come back. And the second time I have them do it, I have them put a rubber band a large rubber band between their knees that's used for exercise. And I have them do that same test. And that forces them to have a shuffling gait as well as a hip tilt. So that is similar to what some Parkinson's patients experience. And it shows them how difficult it is to not only be able to do this test when you have the symptoms, and also how tiring it is to be able to walk, to try to walk in that way. Next slide. So why is balance and gait so difficult in Parkinson's? It basically has to do with the neurotransmitter functionality in sections of the brain that has to do with balance, in particular the basal ganglia. So this section is where the regulation occurs in terms of being able to make smooth movements, as well as being able to do things easily, switching from one cognitive thing to a different physical type of activity. It also contributes to postural issues. So your feet are too close together and you're bending forward at the hips. So it takes your center of gravity and shifts it forward, making it a lot more difficult to be able to balance yourself. It also shortens stride. So as the stride also shortens, you're more likely to basically trip over your own feet or on surfaces or objects that are there. Usually it doesn't start with a strength issue. Weakness is not a early indicator of Parkinson's, but it can occur as the condition develops and the body has more alterations. Next slide, please. So Michael J. Fox, I was listening to one of his books, and it's called No Time Like the Future. And in it, he basically succinctly describes Parkinson's as more of a physics type of equation. So he gave the definition of the uncertainty principle created by Warren Heisenberg. And this principle basically, it says that you cannot know both the position and speed of the particle, such as an electron or proton, with perfect accuracy. The more you nail down the particle's position, the less we know about the speed and vice versa. So if you replace the word particle with your extremities, then you have an idea of what Parkinson's patients or people with Parkinson's disease are really experiencing. In essence, it's difficult to pin down where your body part is as it's constantly moving, because that movement masks its position. And because you're unable to identify the location as well as the movement, doing both at the same time, then it leads to these secondary types of compensations, such as the shuffling gait, the pinging of the hips, and all these other motions to try to have your brain acknowledge the position and have the position be basically stable enough for movement. Next slide. So there's many methods of reducing balance issues, and each one has been tested scientifically, and we'll go through each separate one, but cueing is an important one. So there's different ways and methods of cueing. So it improves gait and arm swing, and arm swing is critical for gait because if you take just a skeleton model and you move the hips back and forth, the motion of the hips will move the arms as it swings to allow balance to be present locally. You'll notice that when patients do have Parkinson's or living with Parkinson's, they do not have an arm swing because their hips are not moving, causing isolation, and that adds to balance issues. So being able to use cues in order to improve balance, arm swing, as well as gait functionality in general is very helpful. There's different ways of cueing. There's what's called external cueing with different types of devices. There's internal cueing with the use of music, songs, metronomes, and each of these helps to allow the patient to have a rhythm that allows for more succinct motion and movement. Physical therapy is really, really important for all aspects of Parkinson's disease. And the sooner you're able to get involved, the slower the progression becomes. There's an example of different categories of physical therapy based on where you are in the spectrum of this illness or disease. And one is called LSVT therapy, which we'll talk about. There's a lot of research as well that talks about, which we'll go through, different aspects and elements of physical therapy and how they give long-term improvement. There's also somatosensory orthotics, which is one of the things we do in our office. So it's found that these types of devices that go inside shoes help with improving balance, movement, and the texture of the covering itself helps to improve tactile sensation. So you're able to have another point of information for that stability to be more fluid. Next slide, please. So let's start with the LSVT physical therapy. So it's named after Miss Lee Silverman, and Lee Silverman was one of Dr. Lauren Romig's first patients who suffered from Parkinson's disease. And they were able to help her in her overall functionality, as well as her speech with using the loud version of LSVT. So loud LSVT helps to overcome the speech-related issues that are associated with Parkinson's disease. So using the voice as well as more normal loudness levels while speaking and changing their interactions, their patients are able to know how loud or soft they speak with other people and can feel comfortable using a stronger voice as a normal loudness level. This is critical because not only does this help to give the patient the ability to communicate with their loved ones and feel a part of a environment that they're comfortable with, They also allows them to advocate for themselves and be able to tell patients, family members, physicians, healthcare workers what they really want and do it in a way that best honors what they want with their activities and lifestyle. The second version of the LSVT is referred to as big. And these are generally big movements that have to do with widening the stance, improving of gait, improving arm swing, improving balance, as well as the rotation of the waist. And research shows that these small and large movements help to really improve motor activity in the portions of the brain that may be affected by Parkinson's disease. In addition, each of these is done one-on-one with a skilled therapist that is able to assess the individual, find where they are in their progression, and be able to be consistently active in their care to provide the best possible outcomes. It's not a type of therapy that's done lightly. It usually consists of 4 days a week, an hour each of these sessions to help to make these strides and improvements and make them so that the patients themselves are able to be comfortable with the outcomes. Next slide. So let's talk about some newer research. And this is basically research that was done in the last 10 years or less. There's 2 factors involved with stability, the width of stance and the stride length. Generally, the smaller, as well as the smaller and faster steps, reduce coordination, but don't increase the risk of freezing or episodes of freezing. It's helpful in terms of therapy that allows for improvement of the width of stance as well as stride length. So treadmill exercises have been found. A 5-week regimen of that has reduced the time to get up and go test. And it also has found to have repercussions of improvement for months afterwards. The other types of therapy that are also, it's not mentioned here, that are also helpful are finding methods to notify the patient where their heel position is so they can, when they stand, broaden their stance and have a starting point that is more comfortable and effective, and that helps to reduce the possibility of falls. They're looked at the combination of land versus land with water physical therapy, and they found that both had similar improvement levels in both of those gait, stride length, and single double support time, which is the amount of time that your foot is on the ground while the other one is moving. And the outcomes are consistent thereafter. They also found that auditory cueing is more effective than visual cueing. So listening to music that you've listened to all your life, which you know the beat for, and that's more of a auditory cueing, or singing a song that you love to sing, is able to help you better understand the rhythm of your feet than external cueing. External cueing being with the metronome or a cane that has a laser or other types of methods. But the rhythm stimulates the brain region that may be lessened in terms of its effectiveness by having and being affected by Parkinson's disease. Next slide. Also, like I was mentioning before, the somatosensory orthotics. Orthotics are custom-made devices that help to improve balance and stability, and they have for many, many years for a wide selection of the population. We make them consistently, effectively for many conditions. In this case, these are modified orthotics that also put pressure underneath the big toe, as well as the first metatarsal head, which is the bone that's directly, the prominent bone that's directly underneath the big toe. And by doing these, they help to increase the stride length as well as gait velocity, increase rotational movement, as well as the velocity and decrease the number of steps that are required. And after even using the orthotics, the effects are still present up to 24 hours after their use. Significantly high correlation is also indicated, and this is really important, between foot health and the quality of life in patients with Parkinson's disease. Simple things such as maintaining, reducing, or eliminating different types of mechanical pressure that leads to different sections of pain, maybe from skin conditions, joint conditions, tendon or soft tissue conditions, has been really helpful in helping to improve both the patient's quality of life and their longevity. Next slide. So that's where my specialty comes in. We are educated in knowing normal versus abnormal in both gait and balance, being able to evaluate patients as well as treat different types of specific foot conditions based on what their cause is, as opposed to just the symptoms alone. We provide custom orthotics for those that are found to be functional and necessitate their improvement. We educate patient on proper footwear to allow for more of a functional gait, as well as fall prevention tactics and surgery if needed. Next, please. So let's talk about dystonia. Dystonia is unfortunately one of the aspects of this condition, and really it can be treated by multiple different ways. Medications are commonly prescribed to help to reduce the intensity of the symptoms, as well as improve the Parkinson's presentation. Botox is commonly used and is highly recommended for a type of dystonia that's more localized. And it basically, for a period of time, uses botulism toxin to decrease the functionality of specific nerves that help to, that are causing the dystonia to occur. It needs to be done by a physiatrist or a pain management or other types of modalities that are specialists that are familiar with the application of this condition, and there is a definite time frame for when it's most effective and when it wears off. Deep brain stimulation is another tactic which we'll go into in the slides to come, but basically it's a surgical procedure that implants either one or two electrodes depending on the condition and severity and the location in different parts of the brain that are used to control motor functionality. Usually it's in the subthalamic nucleus, as well as the globus pallidus interna. These sections, which are Latin, of course, are really the parts of the brain in terms of the groups of cells that help to determine functionality and smoothness of rhythm. And by giving that consistency of input, it allows them to have less overall symptoms, as well as a more smoother communication between the cells. Physical therapy, once again, is really important, and not only does it help with the maintenance of muscle activity and tone, it can be used for rehabilitation, and it's helpful for reducing the symptoms associated with the dystonia, as well as Parkinson's in general. Different kinds, both occupational and physical, which is what the big and loud also coordinate in terms of therapy, have provided individualized improvement depending on the type of goal associated with each individual. Next. So once again, let's talk about the deep brain stimulation. It requires some, in essence, specific criteria in order to be found to be beneficial for Parkinson's patients. To qualify, you need to have had the condition for at least 4 years. And this is key, you have to have a beneficial outcome and response with medications. There requires a full evaluation, both by neurology as well as neurosurgery and a mental status exam. It does not cure the disease. What it does is that it decreases the symptom and reduces the requirement for medication, but it does not slow or stop the progression of the Parkinson's. Not all kinds of Parkinson's disease qualify for this. It's only those with motor symptoms, such as tremor, slowing or stiffness, involuntary symptoms, and dystonia. And it's not intended for balance problems or non-motor symptoms or freezing of gait. In order to be qualified for this as well, you have to, and this is where the mental status exam is really critical, you cannot have any indications of or potential signs of dementia, because doing the deep brain stimulation with these underlying conditions will make them worse. Next. So let's talk about freezing of gait. This is a busy slide, but it goes through the different aspects of treatments possible for freezing of gait or FOG. Freezing of gait can occur in particular when transitions are present between going from inside the room to outside the room over a doorway, or if the flooring is varied from one location to another, but other things and conditions can also contribute to this. Medications are helpful in order to boost dopamine levels, and then also to improve modalities, mobility, and physical therapy, once again, is really beneficial for this, as well as other different aspects and conditions associated with Parkinson's disease. Deep brain stimulator will also be beneficial for these patients, depending on the extent of the progression of their freezing of gait that develops. Again, gait restraining exercises. People suffering from Parkinson's have reduced their symptoms of freezing of gait by doing gait restraining exercises such as cueing and rhythm auditory stimulation. These activities improve they provide an external rhythm to help to improve the stepping process. Even listening to, if you go on, whenever you have time, if you look up on YouTube, you can see there's a very amazing video that shows patient Lynn, one of my movement specialist friends, showed me this. It shows a patient with advancing Parkinson's walking with a typical shuffling gait with the use of a walker, pitched forward, and then they, with headphones, turn on his favorite song that he's known for extended period of time. And within seconds, his gait, his rhythm, his ability to have a wider stance and improved posture really shows. So having that cueing that's auditory is critical and helpful for that. Assisted devices such as canes, walkers, rollouts, these also are helpful in reducing or minimizing falls, but also they can help with some aspects of freezing of gait. Next slide, please. So tardive dyskinesia. Unfortunately, this is a condition that can occur, and it can be found with the PIDG form, because especially in those who have the early onset, as you're on medications to treat the disease, it can cause side effects. Tardive dyskinesia is one of them. Switching medications and also managing and avoiding the excessive or the reoccurrence of overuse of medications may be helpful in terms of determining the on and off phase of the medication, and determining when the off phase is least likely to cause issues, so that less of a dose can be utilized of the dopamine types of medications that are prescribed. Then discontinuing medications that may be contributing to the side effects. Vitamin supplements, many different studies have looked at various different vitamins, including vitamin E, coenzyme Q, but also glutathione. Glutathione is a naturally present antioxidant that's in the body, and it's used by the body to treat and to help with many different kinds of aspects, maybe from exposure to different toxins to association with Parkinson's. The studies have found that even though there's oral, intravenous, and intranasal application of these, the intranasal one is the one that's most effective in terms of providing glutathione to the brain in the areas that are necessary. The caveat with vitamin supplements in general, as well as with glutathione, is that this is a non-regulated part of our use. The FDA does not regulate both the active ingredient nor the concentration in these medications. It does not also regulate the advertisements associated with them. So just be cognizant, as well as discuss the potential benefits as well as risks of these with your medication that's already taken. Talk to your specialist, neurologist, before instituting these supplements into your diet. Botox, once again, is helpful for tardive dyskinesia, similar for decreasing or limiting the extent of the muscular contracture. Physical therapy is also, once again, very helpful too. Next slide. So I do have this come about at times when patients have Parkinson's disease and they need to have a surgical intervention performed. Patients living with Parkinson's can still have surgery. Now, this may be a misnomer in terms of patients thinking that because they have Parkinson's, they are more prone to complications, and then sometimes, depending on the procedure, that can be true. However, because of the fact that this is a progressive disorder that affects multiple systems and decreases functionality, the relative amount of pain and immobility that can be relieved by the procedure that is potentially indicated may outweigh the risks associated with complications. In addition, because it's a progressive condition, the need for a procedure does not reduce with time, it actually increases with time, as do the potential risks and side effects as the disease progresses. So having the intervention earlier on when it's necessary, as opposed to waiting, is beneficial in terms of helping to improve not only quality of life, but consistency of activities, once again, physical therapy, and all the other elements that will help to lessen the progression. Next slide. Now, one last thing in terms of the surgery, it's very, very important to have a team approach when it comes to any type of surgical intervention, even with associated with joint replacements such as knee and hip conditions. You want to have a team approach between your orthopedist, the podiatrist for foot and ankle issues, along with the neurologist, primary care, and be cognizant of pitfalls and how to avoid or prevent them before going into the surgical intervention. So let's talk about some stretching. And these are simple stretches that can be done to help to decrease or limit a lot of the stiffness and a lot of the likelihood of balance issues associated with irregular positioning of the foot and the ankle. So one is the seated manual ankle toe stretch. So as the picture shows, we sit at the edge of the chair. You put one leg over the other in a figure 4 type position. You put your fingers of one hand through the interspaces of the opposite foot, holding at right above the ankle, and you gently move your hand while holding the toes in the front of the foot and keeping the leg stable. You use it in a circular motion, in a windshield wiper motion, and then you can turn your elbow in and out, helping to reduce or limit both the stiffness as well as the muscular tension in the ankle, the midfoot, as well as the forefoot and the toes. This can be done for as long as you like, as the stiffness is there. And then you change positions and you can do the other side as well. Next slide, another seated type of stretch that's helpful is the seated calf stretch with the strap. So you can use a strap, but you can also use a belt, you can use a towel, anything that allows you to gain access to the front of the foot, keeping your foot with the heel down on the ground. So with your heel on the floor for stability and balance, you pull the strap toward you, basically pulling the front of the foot up toward the shin, and you hold for about 3 seconds or so, and then you can let go and do the same thing, doing it 5 times on each side. In the advanced version, you can also move the strap closer to the toes. You can also pull back on the toes, doing the same thing, or you can turn your ankle, twisting toward the little toe or the big toe, as well as pulling at the same time. Next slide. Another seated type of activity for range of motion and movement is the ABCs. So as you're sitting, just like the picture shows, you lift up your foot. The picture has a person with a shoe, but you don't necessarily need a shoe on. What you do is you start off with making an A, moving your foot up, down, and across. You move over to a B, going up, around, making 2 semicircles. Move over to a C, a D. All capital letters going through A to Z, and you will feel quite a bit of um, stiffness be resolved or relieved. We do this exercise as well for people who have ankle instability as well as previous ankle sprains, because it helps to stabilize and support the ankle quite a bit. And then you repeat the same sequence on the other foot and ankle. The next slide will show the seated windshield wiper or rainbow with a ball. So you can use a tennis ball, you can use a bocce ball, you can use any type of rubber ball. You put it in the front of your foot, once again with the heel down on the ground for balance and control. And what you do with this is you slide your foot from one side to the other, making sure that you are rotating at the ankle joint, going from the big toe area to the little toe and back again. You do it about 10 times on each side. Next slide is the standing exercises. So these are great for the lower extremity, in particular, the gastroc soleus and the posterior chain, which is consistent of the heel, the Achilles tendon, the gastroc soleus complex, as well as the quads and the hamstrings and glutes. So you place your hands against the wall, pushing forward, making sure that one foot is behind the other. The heels of both feet are down. You will feel a stretch in the back leg. Hold it for 5 seconds, and then let go of the wall. Tilt your hips up and back, and that will give you that second stretch by rocking to the heel and the front foot. You will feel a stretch along that posterior chain, and then you do the same thing on the other side. Doing this a couple of times will help to improve the motion and mobility of not only the gastroc soleus or the calf muscle, but also the posterior aspect of the legs. The next slide. This is a standing version of that other exercise with the tennis ball, except this one, you roll it into the arch area, going from the heel to the toe. And if you feel a specific area of tightness, you can hold it in that area, going in a circular motion as a release, and then you can continue. You do the same thing on one side versus the other side. This usually provides a lot of relief for patients that may have stiffness, in particular around the plantar fascia. Next slide. So these are my resources. You can feel free to look through them if you like. I'll be happy to take questions.
Okay, thank you so much, Dr.
Oh,
Sanandaji.
you're welcome.
We have quite a few questions in the chat, and 2 of them actually are related to treadmill. One is saying stiffness in foot causes much pain when on the treadmill, and the second one that relates to that from a different person, from Linda, says, how much treadmill exercise time is needed to see improvement? So can you address that a little bit about
Sure. So in
treadmill?
terms of the stiffness that may be present when you're on the treadmill, that's why the stretching protocols are really helpful to do before that level of activity, because that stiffness or tension may be associated with many different aspects, including not only the plantar fascia, the 4 layers of plantar muscle that are present in that area, but also limitation of motion associated with the ankle as well as the midfoot and the toe joints. So getting to the point where you feel comfortable and you feel, in essence, quote unquote, warmed up before you get on the treadmill will be really helpful in reducing or minimizing that. If not, the type of shoe that you wear, as well as using a sensory orthotic, may also be beneficial. In terms of the length of time on the treadmill, studies have found that consistency of use is more important than timing of use. Everyone is different in terms of the amount of minutes required. However, anywhere from a 15 to a 30-minute exercise on a regular basis is found to have positive results.
Okay, thank you. Also, Suzanne is asking, her husband uses a one-step walker and recently started to lean forward and on tiptoes. And she says she has to constantly remind him to stop and use his whole foot. Any advice as to how to improve this type of walk, which is new for him? So I think this might relate to anyone that's learning to use a walker.
Right. So the issue with the walker is this: you have 4 posts, and these 4 posts, depending on where you are in relation to where the walker ends, you find that you may be tipping or tilting forward in order to catch up to where the walker is. Most of the time when we educate patients in physical therapy is critical for this on how to use the walker effectively. You want to be within the confine of the walker and not have the walker leading your gait. That's number one. Number two, it goes back to stiffness that may be present associated with the gastrocsoleus, Achilles tendon, and other elements that may need to be addressed. Number three, it may be also associated with other types of either cognitive or physical issues, and it's difficult to give exact information without assessing the patient, but getting into a good physical therapy program that will deal with both mobility as well as balance, as well as proper education for the use of the device is helpful. But in general, being in the middle of the walker as opposed to having the walker ahead of you and stepping is helpful for that.
Thank you. And Linda is asking, I mean, I may mess how I say this, somatosensory orthotics diminish neuropathy in toes?
Neuropathy, unfortunately, is a end product of multiple different types of conditions. So you have patients who have neuropathy that develops from diabetes. You have patients that have neuropathy that develops associated with spinal issues. You have patients that have neuropathy that develops because of the medications that we're on or are on. You have alcohol-induced polyneuropathy. You have neuropathy related to trauma. So because of the fact that neuropathy itself is related to a category that has to do with nerve damage, it varies depending on the type and the extent. Somatosensory orthotics are usually more helpful in those people who don't have neuropathy, but do have the ability to have an extra ability to provide an increased amount of sensation. Once that sensation is gone, then the orthotics may help to provide stability and support, but in another way, they may be contraindicated if they're preventing you from feeling where you are against the ground.
Okay, thank you. Another question, is Morton's neuroma commonly associated with Parkinson's?
Morton's neuroma can be a condition that is associated with because of the shuffling gait, shifting more of the body weight into the forefoot area. And unfortunately, having that impingement or that pressure cause irritation of the nerve that's in between the third and fourth metatarsal head. Dr. Morton, the guy who came up with this diagnosis, actually named it incorrectly. It's not a neuroma, even though it's referred to as a neuroma. A neuroma is a tumor in a nerve. This is more of a neuritis or an inflammation of a nerve. that has to do with biomechanical issues as well as repeated trauma. So being able to treat the condition will not only require the use of, at times, orthotics, injections, modifying shoe gear, but also addressing the gait pattern that could be contributing to the condition itself.
Okay, thank you. And I have a feeling this next one may apply to a lot of people. I wear through the bottom of my right shoe. Would orthotics be helpful? I think a lot of people talk about that one shoe is more dominant than the other.
Yeah, it has to do with a combination of shuffling gait. Some people have a leg length discrepancy as well, especially if you've had a hip or a knee replacement that can contribute to the condition as well. So having uneven wear patterns is not atypical, especially because of the way that the movement is occurring. Uh, that can be addressed potentially with the use of the custom orthotic based on the cause. So an evaluation is usually the next step to determine if you are a candidate for that or not.
Okay. I don't know if you can do anything about this one, but any advice as how to fight an HMO insurance that says acute PT is not medically warranted? I'm constantly appealing denials, which takes months to resolve. I'm sure you've heard this before too.
Yeah, so this is an issue, and this is why our office doesn't take HMO patients, because it's really frustrating to be able to give the patient hope and give them the ability to know that the treatment is out there, and have a external party limit or prevent the ability between the doctor and the patient to have a game plan that will be more likely to benefit their quality of life. It's sometimes better not to chase windmills, but if you find and if you have the resources to have a private physical therapist come to your home that is able to provide you that benefit, then while you're fighting for the HMO to approve it, you're still getting the treatment that you need. Don't limit the quality of your life or the ability for you to limit or prevent the progression of this disease because of some other person's perspective on what is or isn't effective. You know your body better than anybody else does. You know how you feel, you know how well the physical therapy makes you feel, and you know that with the research that's shown that if you don't have these treatment aspects, it will not get any better, it will get worse. So being your own advocate is great, but also looking at other methods and resources is critical.
Mhm. Okay, thank you. There's a couple other things here. One is a slight curling of toes on one foot indicative of a Parkinson's issue?
That's usually indicative of a muscular imbalance, and that could also be related to several different aspects, not necessarily only Parkinson's. Usually, Parkinson's is not unilateral, it's bilateral. So, all the toes would be affected generally. If it's on one side, then that could mean that it's associated with a neuromuscular disorder that could be affecting that side. You should have, if you haven't already, an evaluation of the spine, as well as a determination if sciatic or other types of nerves are impinged, contributing to that condition.
Okay, and we also have a question about hammer toes. If is a hammer toe a result of Parkinson's, and what can be done without the pain associated, or what can be done about the pain that's associated with it?
So hammer toes, there's different flavors and varieties and different conditions that contribute to them. But generally, a hammer toe is any type of contracture within a toe that limits the functionality of that digit. It can be genetic. It could be associated with shoe gear. It can be associated with Parkinson's. It can be associated with different types of compensations for different musculoskeletal conditions or abnormalities. So a hammer toe itself is mainly that contraction. However, there's different variations based on the level of extent of the condition. So you can have a hammer toe that is treated with the use of stretching techniques, pads, orthotics, modifying shoe gear, different methods of treating the primary cause if possible. If nothing seems to be affected or working, then surgical intervention can be helpful depending on the individual and the extent of the deformity.
And if surgery is, somebody else asked, if surgery is required, are there types of sedation that should be avoided?
Most of well, that's a great question to ask your neurologist as well as the anesthesiologist. However, in most of our surgeries, we don't use general surgery techniques. Most of them are done with IV sedation and local, and that doesn't cause, because we don't use paralytic agents, any issues with muscular related conditions. But um, that's a good question, and I'm not sure. I would have to look into that.
Okay, thank you. I have one more, and then we're going to go to live. If someone has a question, they can unmute themselves and say their name and ask. There's one more here. I have severe neuropathy in my feet, which began about 4 years after being diagnosed with PD. It is so painful at times that I can't walk. How can I minimize pain? Any suggestions? I know that's a common one.
Yeah, so that's common. Depending on the condition severity as well as the overall individuals, other comorbidities or
Hello?
conditions. There's different conditions that may be helpful, different treatments that may be helpful. There's the use of topical related products. There's the use of oral medications. There's also the use of different types of spinal stimulators. So they're similar to the deep brain stimulation that's done. They do a similar type of stimulation in the spinal region associated with where the burning and tingling are created or elicited, and that helps to calm down or prevent the symptoms.
Okay, thank you so much. Do we have anyone that would like to ask a question? If there is no one else, Dr. Sanandaji, thank you so much. We really
My pleasure.
appreciate you joining us today, and it has been very informative. I just want to say we are excited that PCLA has been chosen to be an official charity partner of the LA Big Five race, which is part of the Los Angeles Marathon. And we're inviting all of you to join us in person or virtually to help us raise funds for our support and education programs for our particular community of Parkinson's disease. We have some great events coming up. Join us next week to learn how you can become an effective advocate for people living with Parkinson's. Next month's events will cover how to meal prep for Parkinson's and how you can contribute to one of the largest PD research studies in the world. We'll also learn about a new treatment that targets off times. Links to register for these events, as well as updates for all of our programs, will be sent to our email list. And today, again, remember that this event was made possible by our sponsors, Abbott, Boston Scientific, Medtronic, Kyowa Kirin, and Supernus, and especially you. By donating to PCLA, you can join us in our mission to improve the lives of the families in our community who are living with Parkinson's. PCLA is a nonprofit, and all donations are tax deductible. If you enjoyed today's program, please consider donating at pcla.org to help us continue to provide programs like this for free. As always, reach out to us with questions at info@pcla.org or by phone at 310-880-3143. Thank you, Dr. Sanandaji. And
My pleasure. Thank you, Judy. Thank you for having me.